So welcome to the Kanski lecture series, and this is going to be the acquired macular disease part 7, and in this part we are going to discuss about the retinal angiomatous proliferation. So retinal angiomatous proliferation means that there is going to be the proliferation of the arteries or in the within the retina. So it is not outside the retina pre-retinal, which is known as the retinal neovascularization. It is within the retina. So retinal angiomatous proliferation (RAP) is a variant of the neovascular AMD type 3 in which the major component of the neovascular complex is located within the retina. The process may originate in the deep retinal capillary plexus or within a choroid. So most of the time it arises from the deep retinal capillary plexus or within choroid, in the later case with the early formation of the retinal choroidal anastomosis. The disease is frequently bilateral and symmetrical and is probably underdiagnosed. It may constitute 10 to 20% of the neovascular AMD in white people. So next is the how do you diagnose this condition. Diagnosis is presentation is similar to CNV, but PED and exudate are more frequent. So pigment epithelial detachment and exudate are more frequent. Hemorrhage are also more common and tend to be superficial and multiple. So there are three stages: stage 1, 2 and 3. Intraretinal neovascularization, dilated telangiectatic retinal vessels and a small angiomatous lesion typically accompanied by the intra, sub and pre-retinal hemorrhage, edema and exudate. So whenever there is an intraretinal neovascularization, it will be visible as a dilated telangiectatic retinal vessels and small angiomatic lesions, which can also be accompanied by intraretinal hemorrhage. It can be subretinal hemorrhage or pre-retinal hemorrhage and edema as well as exudate. Stage 2 is a subretinal neovascularization extending to the subretinal space associated with increasing edema and exudate. A serious PED may be present. So stage 2 consists of the subretinal neovascularization. First was intraretinal neovascularization. Stage 2 is a subretinal neovascularization. Stage 3 is a CNV. Profusion is principally choroid with RCA formation. CNV is clearly evident clinically or angiographically. A disciform scar will often form. OCT demonstrates a neovascularization as a hyperreflective area. So whenever there is a neovascularization, it will appear as a hyperreflective area in the OCT. Other features depend on stage. ICGA is a diagnostic in most cases, showing a hot spot in the mid or late frames and frequently a perfusing retinal arterioles and draining venules. Hairpin loop when linked. Fluorescent angiography is usually similar to occult or minimal classic CNV but may show focal intraretinal hyperfluorescence. So FA will show as a occult or minimal classic CNV. So how do you treat this condition? Anti-VEGF therapy show encouraging result. Favorable outcome in combination with PDT have been reported. Limited success have been reported for other modalities including PDT alone and photocoagulation of the feeder vessel, though later may be used in the resistance cases. So anti-VEGF can be used for the treatment of the retinal artery angiomatous proliferation, and sometimes it is also combined with PDT, and other modalities include PDT alone or photocoagulation of the feeder vessels. Next is a polypoidal choroidal vasculopathy. So polypoidal choroidal vasculopathy is like there are in the choroid there are vessels and there are polyps that are being formed in the choroidal vessel. So this is known as a polypoidal choroidal vasculopathy. So polypoidal choroidal vasculopathy belongs to a specific spectrum of term condition characterized by pachychoroid, in which the disturbance in the choroidal circulation seem to be central to pathogenesis. It is characterized by the branching vascular network of the inner choroidal vessels with multiple terminal aneurysmal protuberance that appears to be the source of bleeding and exudation. So you know that there are inner choroidal vessels and they have like a aneurysmal like proliferation, like polyp formation, and that result in bleeding and exudation. It is more common in patients of African and East Asian ethnic origin than in white and is more common in women than men. 5:1. The disease is often bilateral but tend to be asymmetrical. Risk factor include cigarette smoking, increased body mass index, and increased level of inflammatory biomarkers. For example, C-reactive protein. So it can risk factors are cigarette smoking, increased body mass index, increased inflammatory biomarkers. Overall, it is relatively common, and the presence of the prominent hemorrhage should lead to the consideration of PCV, particularly if there is an absence of drusen and the patient is relatively young and Asian or African. Diagnosis. Presentation is usually in the late middle age with the sudden onset of the unilateral visual impairment. So, the late middle age present with this type of lesion, and there is a sudden onset of a unilateral visual impairment. So, what are the signs of the polypoidal choroidal vasculopathy? There are terminal swellings are frequently visible as a reddish orange nodule beneath the RPE in the peripapillary or macular area. So, around the optic nerve or in the macular area, there will be like a reddish orange nodule beneath the RPE, and less commonly in the periphery. Multiple recurrent serosanguous retinal and RPE detachments can be present. Deterioration can be slow with intermittent bleeding and leakage, resulting in macular damage and visual loss. So, if there is an intermittent bleeding, this can cause the visual loss and macular damage. Up to 50% may have a favorable outlook with eventual spontaneous resolution of exudation and hemorrhage. FA show intense localized area of hyperfluorescence. ICGA is the key investigation in PCV. Hyperfluorescent nodule and a large network of choroidal vessels when surrounding hypofluorescence appear in the early phase. So, in the ICGA, it appears as a hyperfluorescent nodule, and there is a network of a large choroidal vessels and surrounding hypofluorescence. The polyp-like swelling rapidly began to leak. The previously darker surrounding region become hyperfluorescent by the late phase. A cluster of grape-like lesion may carry a high risk of severe visual loss. So OCT will shows us multiple large pigment epithelial detachments, so there can be present, particularly the double hump sign and inverted V. So there is a double hump sign and inverted V sign. Round oval polyp may be attached to the posterior surface of the PED. A branching vascular network can be seen underlying a flat PED attached to adjacent to polyp. So, if there is a flat ped, there can be polyp can be seen in the beneath the RPE. Choroidal thickening can may be demonstrated. Treatment: the favorable prognosis without treatment in a significant proportion of cases should be borne in mind, and asymptomatic polyps may be observed. So, even the asymptomatic polyps can just be observed. Anti-VEGF agents are less effective than in typical CNV, but may suppress leakage and bleeding. So, anti-VEGF can be used if there is a bleeding and leakage. Combination with anti-VEGF and vertiporphyrin PDT is superior to anti-VEGF treatment alone. So, combined therapy is more effective than a anti-VEGF therapy alone. PDT may lead to regression of polyps and putatively and extended treatment effects, but carries an additional complication risk. Laser photocoagulation of the feeder vessel or polyp may be effective in selective cases, especially if the changes are juxtafoveal. The result of combination therapy of ranibizumab plus verteporfin PDT are superior to ranibizumab monotherapy in the respect of a breast-corrected visual acuity and complete polyp regression, and fewer injections are required. Everest 2 trial. So Everest 2 trial is basically the trial in a case of a polypoidal choroidal vasculopathy, which shows that if you combine ranibizumab plus PDT, it is more effective than ranibizumab alone. In a patient with AMD who has not responded to anti-VEGF treatment after 3 months, undertake ICG angiography to check for polypoidal choroidal vasculopathy. So this is a retinal angiomatous proliferation type 3. A is showing us a drusen and a small intraretinal hemorrhage at the macula. B is showing ICGA early phase, showing hyperfluorescence of a front hotspot. So this is a front. C is showing FA early venous phase, showing faint hyperfluorescence from a small front of intraretinal neovascularization. So this is shown in the in the early venous phase. D is showing late venous phase, showing hyperfluorescence of the neovascular membrane and surrounding drusens. This is a polypoidal choroidal vasculopathy with exudative feature. A is showing reddish orange nodular terminal swelling with surrounding leakage, so there is a leakage in this area. B is showing FA appearance, fluorescent angiography appearance. A is showing in late venous phase, showing intense of A. B is showing fluorescent angiography of A in late venous phase, showing intense localized area of hyperfluorescence. C is showing early ICGA of appearance of a polyp. So you can see this is a polyp here. D is showing late ICGA appearance of a polyp. Next is a peripheral exudative hemorrhagic chorioretinopathy. Peripheral exudative hemorrhagic chorioretinopathy is an uncommon disorder affecting predominantly older women. It typically manifests with peripheral retinal hemorrhage, exudation, and PED associated with CNV. It is bilateral in substantial minority. The visual prognosis is often good, but the macula may be involved by extensive disease. The etiology is unknown, though it may also may be a form of a neovascular AMD. Some cases share characteristic with polypoidal choroidal vasculopathy. Treatment for sight-threatening disease generally consists of intravitreal anti-VEGF injection. Next is an idiopathic choroidal neovascularization. Idiopathic CNV is an uncommon condition that affects patient under the age of 50 years and is usually unilateral. So whenever the CNV is caused without any reason, it is known as idiopathic CNV, and it is uncommon condition that affect the patient age under 50 years, and it is usually unilateral. The diagnosis of exclusion of other possible association of CNV in younger patients such as angioid streak, high myopia, and chorioretinal inflammatory conditions such as presumed ocular histoplasmosis. So one should exclude basically angioid streak, high myopia, POHS before to rule out this disease. This condition carries a better visual prognosis than the associated with IMD, and in some cases spontaneous resolution may occur. Treatment is typically with an anti-VEGF agent. So that's it for the part 7. See you in the next lecture.